is percutaneous treatment with Örmeci technique for hydatid disease. Hydatid cyst is a disease caused by larval form of Echinococcus granulosus. Adult worm is 3 to 6 millimeter long and 0.5 millimeter broad. It has 3 to 4 proglottis. Parasite inhabits in the jejunum of the definitive host like dogs, wolves, and other carnivores. It releases several thousands of ova, which are then passed in the feces. This is very old disease, historical disease. Hippocrates mentioned in aphorisma about cyst full of water. Incidence and global burden of hydatid cyst. Incidence of hydatid cyst varies 1 to 200 per 100,000 in endemic areas. Estimated minimum global human burden of CE averages 285,000 disability adjusted life years. Annual loss of USD for CE is almost 200 million United States dollars. Financial burden of CE in Italy already is reported 53 million euros. When we look at the geographic distribution of the hydatid disease, as you see in this map, the Middle East countries, East European countries, South African and East African countries, Australia's and South American countries much more common. When we look at the life cycle of hydatid cyst, adult form generally just living in the dogs or wolves' intestine, jejunum. And then every day, thousands eggs just come out with the feces. And if the eggs was ingested by sheep or human being, then accidentally, as an intermediate host, can have a disease. And finally, the hydatid disease just becomes mature, develop bigger and bigger every day, and then finally, when they be cotton, then the some of the organs are ingested by dogs, and came this eggs parasite, and the definitive host can have this disease. And finally, immature forms became mature in the jejunum. When we look at the human beings, when this kind of eggs was ingested by human being, the larva come to jejunum, and by stomach acidity just release from capsule, and then cyst larva just penetrate the intestinal wall, came into portal vein and to also liver, and located there. If can pass through the sinusoid, then come to lungs or other systemic circulation and other organs. Serologic diagnosis of hydatid disease, sensitivity 85% to 98%, and specificity unfortunately low. So generally we diagnose the hydatid disease by ultrasound examination. According to WHO classification, CE type 1 as a pure cystic lesion like this, CE type 2 like a honeycomb. There are many septas like honeycomb, and type 3, CE3, disturbed or separated some germinative membrane from the detaching border. And the type 3B, there are matrix between the daughter cysts. Type 4, wholly solidificated lesion, and this type 4 solidificated plus also calcification around the cyst. We can diagnose If a suspect by ultrasound, sometimes we can apply to CT or MR. CT hydatid cyst appears as a water attenuation cyst with a well-defined wall. The outer cysts appear as a round, peripherally placed cystic lesions in the mother cyst. Floating membranes appear thin and hypodense. High-density fluid surrounding the outer cyst appears as radiating spokes like rosette pattern. During the MR examination, hypodense on T1 weighted images, hyperintense on T2 weighted images, a low signal intensity ream on T2 weighted MR images, like this. MRI accurately shows the hydatid matrix, the outer cyst and pericyst, and also detached endocyst appear as a floating membrane in the cyst like a snake signs. During the treatment also we can understand this is a hydatid cyst or not. When we aspirate the juice like you see here, looks like rock juice. So we can definitely understand that this is a hydatid cyst. If there is a fistula between the cyst and the biliary duct, then we can use MRCP. So according to our experience, we had a deformation of the cyst, focal defect in the cyst wall, or beak-like projection extending from cyst wall like this. And the sensitivity of MRCP was 91.7%, specificity was 82.8% for identification of intrabiliary rupture. Also, we can use ERCP, and also we can use 99M technetium labeled albumin macroaggregate. When we inject the 99M technetium labeled albumin macroaggregate into the cyst, when there is any kind of connection between the cyst, biliary duct, or vessels, or common bile duct, then the albumin, macrogate albumin less than 20 nanogram. So this can pass through this kind of vessels, and directly we can understand that there is a fistula between the bile ducts or vessels or some other spaces. Hydatid cyst, a lot of complication, like a local complication, intrahepatic complications, exophytic growths, transhepatic thoracic involvement, perforation into hollow viscera, such as peritoneal seeding, biliary communication, portal vein involvement, abdominal wall invasion. Also infection, involvement of the more distant anatomic sites due to the hematogenous dissemination, such as lung, kidney, brain, muscle, bone, and spleen, every other organs. Also, rarely the hydatid cyst may have an anaphylactic reaction, and this is a kind of 0.04%. This is from our series. You see here, it's just ruptured into the pleural space. In this case, ruptured into the biliary duct and the common bile duct dilatation, you see here. In this patient, the left lobe cyst, hydatid cyst, just open into the stomach, juice come out here. And we just inserted the metallic stent between the stomach and the cyst. In this case, cyst open to gluteal area. One of the complications of the hydatid disease is the rupture of the cyst into the common bile duct. And because of the germinative membrane, the patient may have a jaundice. In those cases, we do ERCP sphincterotomy, and we evacuate all the bile ducts by balloon, as you see in this picture video. Okay, therapeutic options in hydatid disease, surgical, medical, or percutaneous way can be used. Aim of the surgical treatment of hydatid disease: relieve symptoms, inactivate and completely remove viable scoliosis and germinative membrane, and manage the residual cavity. Surgical treatment can be conservative or radical. You see conservative treatment: simple tube drainage, marsupialization, capitonage, deroofing, and something. And radical treatment: total peristectomy, partial hepatectomy, or lobectomy. Morbidity of surgical treatment is 32%, mortality 0.0 to 8%, recurrence rate changing depend of the center and center, and almost 0 to 20%. Hospital days are longer than percutaneous way or the other treatment ways. Also expensive than the percutaneous treatment. Mebendazole inhibits accumulation of tubulin in the microtubule, causes impaired glucose uptake, interferes with the homeostasis of the parasite. Their success rate: mebendazole between 14 to 16%, albendazole 30 to 39%. Oxybenzone still experimental and toxic drug. Praziquantel combined with albendazole. But unfortunately, their recurrence rate is almost 1/3 of the patients after using benzimidazole carbamide. Also, there are side effects of benzimidazole carbamide, such as elevation of transaminases, abdominal pain, distension, termination because of side effects. Praziquantel improves motility of the cestot, impairs such suctional functions, causes strong contractions of all the hooks of the parasite. Dislocation becomes easier, increases the susceptibility of germinal membrane to paralytic enzymes. When we look at the meta-analysis of 46 articles selected from 146, chemotherapy is not an ideal option when used alone. Albendazole is superior to mebendazole. Albendazole and praziquantel combination is superior to albendazole monotherapy. Radical surgery is superior to conservative surgery in terms of morbidity and mortality. Radical or conservative surgery combined with omentoplasty seems to prevent deep abscesses. Laparoscopic intervention is safe for uncomplicated cysts. Further trials are needed for the efficacy of surgery plus chemotherapy combination. Percutaneous therapies with albendazole combination is superior to surgical treatments. PER technique was reported in 1987 by Dr. Ben Amor. They use the Seldinger technique, puncture the hydatid cyst, aspirate whole of the juice, and then inject scleroticidal agents such as hypotonic saline or nitrat d'argent or cetrimide something. And finally, wait 20 minutes and then aspirate whole juice. But if the cyst more than 4 centimeters in diameter, then they use the catheter and they wait the juice come out totally, and finally, when they stop juice coming outside, then they just remove the catheter. In PEVAC also use large bore catheter into the hydatid cyst. You see here. MOCAT technique, modified catheter technique, also they used large bore catheter into the hydatid cyst until whole inside scolex came out and cleaned the cyst until the cleaning the cyst. In Örmeci technique, we use generally under sedation, the technique. As you see here, our team, anesthesia technician, anesthesia doctors, nurse, assistant doctor, and the staff, and me, this is me. So we just use ultrasound examination only. The patient lie down on spine or in the left lateral position or right lateral position according to the location of the systemic hydatid cyst. So indications of percutaneous treatment, we generally treat the garbage type 1, garbage type 2, garbage type 3, but seldomly, if garbage type 4 actively secreting juice increasing and the diameter of the cyst are increasing, then in this case we just treat those cases too. Infected hydatid cyst, we just treat it like an abscess. Contraindications are inactive or fully calcified cyst, type 5. Cyst known to have overt communication with biliary tract, and non-cooperative patients, we don't treat these patients. So we have diagnosed 1,556 cases and 1,004 cases. You see, mean age 44, youngest 4 years old, and oldest 86 years old. Female more common than male gender. You see here, left lobe of the river, almost 291 cases, right lobe 1,090 cases, spleen 82 cases, kidney 13 cases, peritoneum 19 cases, muscle 24 cases, multiple hydatid disease in 14 patients, and unusual localization 23 cases, and totally 1,556 cysts were diagnosed and 889 were treated. So when we look at the outcome of the patients with Örmeci technique, we have evaluated the cases in terms of decreasing of the cyst, pseudo-solid pattern, one part or two part or total pattern, or minimal changes or calcification or detachment of the cyst membrane or disappearance of the cyst. So you see here cyst type 1, cyst type 2, 3A, type 2 and 3B, and the evaluated numbers as you see here. According to success rate of Örmeci technique, the overall clinical success with the Örmeci technique in our case series was 94.5%. The risk of failure in WHOCE type 2 and WHOCE type 3B hydatid cysts were threefold higher than in type 1 group. Dr. Kabaleoğlu and Georgia reported their success rate as 39% and 41.4% for WHOCE type 2 and type 3B. However, our technique success rate for type 2 or type 3B was 88.18% in our technique. Complication, 12 cases urticaria, 11 cases pain, severe pain, 7 patients fever, anaphylaxis 3 cases, ALT, AST increasing 2 cases, and hypotensive attack 2 cases. There are differences between the pair technique and the Örmeci technique. Pair technique use 18 to 20 gauge needle, but we use 22 gauge needle. Why? Because if you use thicker needle, then you may have a leakage of the juice, and you can have a recurrence. Because of that, we generally use thinner as much as possible. CYST fluid, pair technique totally aspirated, but we just aspirate the same as amount of injection. Sclerosant, hypotonic serum, pure alcohol, cetrimide or nitrate darjan in pair technique, but in our technique we use alcohol plus polydocanol. We use polydocanol the first time in the literature because, as a gastroenterologist, we generally use polydocanol for stopping to esophageal varices. So I suppose that if we use a polydocanol inside of the cyst, then if there is a connection between the cyst and the duct, biliary duct or vessel or any lymphatic ducts, then polydocanol may just stop the communication. So we used polydocanol combined with alcohol. Among sclerosants, pair technique generally use huge cyst opaque material, almost 1/3 of the cyst fluid, but we just, according to the size of the cyst diameter, small amount opaque material we used, 80 cc. Drainage, we never use any kind of drainage catheter, but pair use 8 French catheter. Time period until drainage stops, they must wait, and this make a longer hospital stay. In our technique, just 5 minutes wait. After 5 minutes, just remove the needle and watch the patients 2 hours and then see off them to their home. Lanx hospital stay long in pair technique, but in our technique, outpatient basis. We never use chemotherapy, but pair generally use combination with mebendazole or albendazole. In our technique, if it doesn't satisfy the result, then we can repeat and repeat. This is meta-analysis, 21 trial comparing pair plus chemotherapy with surgery for liver hydatidosis. Pair plus chemotherapy cure higher than surgery, recurrence rate less than surgery, major complication, anaphylaxis, fistula, abscess, sepsis, infection, intra-abdominal abscess, less than surgical technique, minor complication, less than surgical technique, but fever higher than surgery, allergic reactions also higher than surgical techniques. Hospital stays less than surgical techniques in pair technique. There are several only randomized clinical trials. This is Crow's study. 50 patients they use and 25 percutaneous plus albendazole. The other 25 were treated the patient's surgical technique. Hospital stays higher in surgical technique compared to percutaneous technique, and also complication higher in surgical technique compared to pair technique. Cost also very expensive compared to percutaneous way. Median almost 11,000 euros were calculated in the study. In our study, we never see any fistula and also recurrence. We never see any recurrence. Also mortality, we never see any kind of mortality. We don't see fistula because we just small amount aspiration, and we don't have a recurrence because our needle thinner than the other techniques, and also we just use pseudoanaesthesia and also anti-allergic drugs such as any antistine or something. Then we never see any kind of allergic reaction. Seldomly, I mean, we saw only 3 patients we saw. This is a modified catheter technique and just PVAC technique, another catheter technique. They use complicated patients. As you see here, their hospital stays longer and the fistula rates higher, abscess higher, and pleural effusion or second attention 10%. And puncture the cyst. According to diameter of the cyst, we just aspirate small amount of the juice, not wholly. This is very important because we don't aspirate whole juice, because if you aspirate wholly, then the fistula will occur. So we hesitate to evacuate whole juice of the hydatid cyst. We just small amount according to diameter, 3-fold of centimeter in diameter. We just aspirate. For example, let's say 10 centimeter in diameter hydatid cyst, then we just aspirate 30 centimeter cube juice only. And then we gave 2 volume pure alcohol and 1 volume polidocanol. Wait 5 minutes and then just remove the needle, that's all. This is a polyclinic-based treatment. You see, this is type 1 hydatid cyst. We now punctured, little bit aspirated, and then just injected pure alcohol plus polidocanol. This is type 2, like a honeycomb type. You see, after puncture, we just inject the polidocanol plus pure alcohol. But in some cases, we use several puncture at the same time, at the same session. Sometimes 5, sometimes 6, or sometimes less, according to the diameter of the cyst. So this is our first case. Please look at the date, 2 August 1991. This is a 9 years old small lady, type 1 hydatid cyst. I apologize for this bad picture, but that time only we can have this kind of material. After treatment, you see, 2 August, just germinative membrane separated. Few days later, 5 August, germinative membrane detached wholly. And finally, 2 years later, wholly solidified and calcified. This is type 1 hydatid cyst. After injection, like ice boil, and look at, please, germinative membrane became whitish and detached from the wall. Another huge, 164 centimeter in diameter, millimeter in diameter, sorry. This is a needle. After injection, detached membrane. Another type 1. After injection, like ice ball, you see, and germinative membrane became whitish. The same patient. This is another huge type 1 cyst, detached membrane. This is a very huge, again, hydatid disease in the lung, but also we can see from the abdominal area, and puncture from the abdominal area, this cyst cured, and you see disappeared. Sometimes 3, sometimes more. we just puncture at the same session at the same time. We never have any extra complication about this more punction, you see. Yeah, this is type 3B. Actively, there are several daughter cysts and the matrix inside among the daughter cysts. After treatment, fully solidified. Again, type 2, septated like a honeycomb. After treatment, solidified. Type 2, after treatment, solidified. 3B maybe this one, because there are matrix here. After treatment, solidified. Yeah, this is typical type 3B. The outer cyst located just peripherally in the mother cyst, and there are matrix between the outer cysts. After treatment, solidified. So the first article was published in 2001 in American Journal of Gastroenterology, New Percutaneous Approach for the Treatment of Hydatid Cyst of the Liver. And also we used splenic hydatid disease. You see here type 2, two different cysts, this one, the other one. After treatment, cured, solidified. Another spleen cyst, type 1. After treatment, just shrinkage, germinative membrane, and detached from the wall. This is another one, type 1. After treatment, detached the membrane. In this patient, both liver and also spleen had hydatid disease. After treatment, as you see here, germinative membrane detached from the wall. Also, spleen was published in 2002, Digestive Disease and Science. Kidney hydatid cyst also we can treat it easily. You see here, huge hydatid disease in the kidney. The diameter 219 millimeter in diameter. This is the needle during the treatment. After, of course, the cured. This is another one, type 1 in the kidney. After treatment, solidified, you see in the kidney. Also, kidney article was published in 2005, International Urology and Nephrology. There are several muscle hydatid disease we treated. You see here in the right muscle, leg muscle. You see type 3B. There are many daughter cysts between among the matrix. So after the treatment, solidified totally. There are side by side two type 3B hydatid disease. After treatment, solidified, you see. This is a left gluteus maximus muscles. After treatment, solidified. Right legs, you see type 3B. Type 3B. And the hydatid cyst also was published in International Journal of Infectious Disease, 2007. This is ERCP. You see here there is a connection between the cyst and the biliary duct. About 75 patients we do ERCP before and after treatment, because we just want to check any complications such as sclerosing cholangitis or some others. So we never see any kind of sclerosing cholangitis after the treatment. This is also macrogut albumin injection. After the macrogut albumin injection, there is a connection between the bile ducts and the These are the vowels. Also, we published the article, Digest of Disease and Science, in 2005. So the technique was accepted in a puzzle meeting, 2006, Manila. Mr. Chairman, as a conclusion, Örmeci technique is effective and a safe treatment modality for HYDATID disease. It is outpatient basis. It is not necessary for hospitalization. It is not necessary to give albendazole treatment. It is very cheap and repeatable method. It is easy to perform in everywhere and everybody, by everybody. It has less morbidity compared to PER technique and the surgical method. It has no mortality, and it should be used for the first choice of the treatment of HYDATID disease. Thank you very much for your patience.